Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neurorehab for SLPs, a podcast presented by Speech Therapy PD. Brainstorms is designed for adult medical speech-language pathologists working across practice settings and across the lifespan. I hope that this podcast brings you evidence-based practice that's easily digestible and applicable to your everyday practice. Enjoy. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter. Hello and welcome everyone. My name is Renee Garrett and I am your Speech Therapy PD podcast host for Brainstorms, Functional Neurorehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Erin receives a salary from Cincinnati Children's Hospital. She is the co-host of First Bite, a speech therapy podcast, for which she receives compensation from SpeechTherapyPD.com. She also receives compensation for numerous presentations from Speech Therapy PD and also receives profits from the sales of First Bite Boutique. Her non-financial disclosure is that she is a volunteer with the ASHA Pediatric Feeding and Swallowing Disorders Committee for the ASHA 2024 Convention. Additionally, she is a volunteer with Feeding Matters. She's a member of ASHA and a member of ASHA SIG 13 and is also a contributor for the book Chasing the Swallow and a member of the DIR South Carolina Coalition. My financial disclosure is that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. As the host of Brainstorms, Functional Neurorehab for SLPs, and other webinars on Speech Therapy PD, I do receive financial reimbursement. And I am also an adjunct instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the Q&A or the chat box and will be answered throughout the presentation. Now, without further ado, we welcome our friend and guest, Erin Forward, MSP, CCC-SLP, CLC, who is a speech-language pathologist and certified lactation counselor. Erin works as an SLP at Cincinnati Children's Hospital Medical Center in an outpatient setting. She has advanced training in pediatric feeding and swallowing disorders, early language, AAC, and trauma, specifically for medically complex children. Erin holds an advanced DIR Floortime provider certification and is a TBRI trained practitioner. She graduated from the University of Pittsburgh with a bachelor's degree in CSD and psychology, and from the University of South Carolina with her master's in speech pathology. She is the regular co-host of First Bite, a speech therapy podcast with Michelle Dawson, MS, CCC, SLP, CLC, also BCSS, where she shares her experiences and evidence-based practices from her time working in early intervention in home health, NICU, PICU, GI clinic, and outpatient clinic settings. For her dedication to the field, she was awarded an ASHA Distinguished Early Career Professional Certificate in 2021 and is a graduate of the ASHA LDP program. Yay, Erin, thank you so much.
That's a mouthful, sorry.
No, you're good. You're good. It's so good to see you.
You too.
I know. I get to see you in like 2 months, like real life.
I know. I'm so excited.
Yeah, me too. Me too. So just a little background, Erin and I actually did a similar presentation at ASHA last year on trauma-informed care. And recently we were kind of talking about how really we were like like one of two maybe presentations on trauma-informed care. And then this year at ASHA, there are so many presentations. So I don't know if that means we were trendsetters or I don't know. What do you think?
I think so.
We'll go with that. So yeah, I think it's really important to both of us to talk about this and bring to light how, again, this is one of those topics that cross the lifespan, which is why I wanted to bring you on. It's not something that's isolated to the pediatric population, the adult population, or the geriatric population. You know, the trauma and stress surrounding that can really play into a lot of people's lives who have a disorder or not. And so I think that's kind of a great starting point for us to talk about.
Yeah. And I think like being in this space, you think people are more aware of it because you're in this space. And then sometimes I go into other spaces, I'm like, oh, we have so much work to do in everybody being aware of trauma-informed care and what that is, and that it's a shift, but it's not, the changes aren't as like groundbreaking as I think people think that they are. Like they're groundbreaking in that they make huge impact on like a person's experience, but the changes can be so subtle that make a big difference.
Yeah, and I think one of the ways that, you know, kind of another starting point is talking about the definition. And so if you look at the Substance Abuse and Mental Health Services Administration, they talk about trauma being either an event, a series of events, or a set of circumstances that an individual can experience that has these physically or emotionally harmful, life-threatening, lasting adverse effects that can impact things like mental health, physical health, social health, emotional health, and spiritual well-being. And I think, you know, there's a lot of ways, a lot of examples I think we can give of that, particularly recently with the back to back hurricanes, right? We had this terrible storm with Hurricane Helene and then followed by Hurricane Milton. And so both Erin and I are connected to like the Western North Carolina, Northwestern South Carolina areas, and that were really impacted. And then we both have colleagues and friends who live in the Tampa area and also in Georgia. So, you know, I know for me personally, that's affected like my own like mental and, you know, spiritual well-being because I want to fix it and help everybody. And a lot of times people don't think of it in the simplistic terms like that, but that is a big traumatic event for not only those people who just live there, but these are people who also serve their communities in the same roles that we do.
Yeah. And I think when, you know, I was thinking, I forget the week after Hurricane Helene hit, and like I lived in Greenville where they didn't have power for a week. And all I was thinking about was like my old patients that I used to see and like, can they get power to have their ventilators? Can they get power? You know, all of these things. And I could barely focus. So thinking about people who are going through experiences or, you know, that have had an experience that then is brought to light, you know, say they had been through a natural disaster before, and then they see the news of Hurricane Helene or something else that's happening. And we don't always have control over how our body and brain react to that. And what our capacity is when we're experiencing that. And what I love about trauma-informed care and the understanding is that, you know, we aren't always going to know what someone's trauma is. Sometimes we will. Sometimes, you know, we'll read it in their chart of something they've been through, or we'll have a self-disclosure or something like that. But trauma-informed care gives the purpose of assuming that there has been trauma and acting accordingly with this lens of wanting to help someone feel safe. And safety is that huge pillar. So speaking, you know, a natural disaster, a lot of people weren't even physically safe. And so how are you supposed to feel mentally safe when all of that is going on around you too? So that can pose a lot of challenges as well.
Yeah, I know. Even for me, it's very stressful because I'm on the southeast coast of Virginia, and we've had many storms, but a couple of ones that really stick out. Most recently was, well, not most recent. The biggest impactful one recently for me as a parent and a human was Hurricane Isabel, which has been a while.
Mm-hmm.
I want to say it was 2003, so it's been a minute, but we didn't have power for almost 2 solid weeks. It was hot, it was humid, it was late September, and my kids couldn't go to school, and I learned I can make you whatever you want on a grill. As long as I have gas from a grill, I got you. I can make you French toast, spaghetti, whatever you need. But it just, it brings back a lot of memories for me watching these people go through that and thinking about how, a lot of people still don't have access to good health care, much less things like a generator, or maybe they weren't really prepared. A lot of, the younger, I know my own kids, younger generations don't keep up with the weather and watch the news necessarily. And so maybe not were even informed of this. But for some people, it's not even it's direct exposure, but for some people it's the witnessing the event just in
Mm-hmm.
general, or witnessing what happened to someone that they loved, or seeing that first responder repeated exposure to the details of the event via
Yeah.
media or via direct contact. So that is just, I think that's really important to note as well.
There is some research too coming out in the psychology field about the exposure to traumatic events on social media and how, interestingly, watching something happen when you're not there can be not more traumatic, but because you're not there and kind of releasing the emotions in the way that somebody that is there is, it can kind of live in your brain a little bit more. And so I think being really intentional about, you know, I was in the moment of like checking things and looking and watching, but also, take action on what I can, but not exposing myself to that over and over again, because it can, that emotion can kind of stir up other things or make it harder to release, if that makes sense. So
Mm-hmm.
as a society, we're exposed to these things all the time and we don't have the emotions to grapple with it. And from like a pediatric perspective, kids are exposed to things way more than they were in the past, and they may not even have the emotional capacity or self-awareness to understand how to express those emotions, and things move so quickly. And so we're talking, her natural disasters and abuse and things like that. The trauma world will talk like big T and little t trauma, and big T trauma
Mm-hmm.
being those ACEs from a pediatric perspective, or something that has happened to you as an adult that we can really define like this was a traumatic event. And that's something that sometimes we're more aware of. But for a lot of people, trauma can come in very small, things that happen consistently that are small. I think like from a pediatric perspective, or an adult, like a neurodivergent person that constantly
Mm-hmm.
feels misunderstood over and over and
Mm-hmm.
over again, that can be traumatic. Or your sensory system being bombarded, if you have a different sensory processing, can be traumatic. Being embarrassed at school because you have different literacy capabilities, or you're having trouble making friends, can be traumatic. Workplace things happening so there's all these little things too that can also be traumatic. And that's where we all just have to take a step back and recognize that if we use these principles that we'll talk about, that can just help make everyone feel more comfortable and meet people from a seek to understand place as well.
Yeah, meet people where they're at. Yeah,
Mm-hmm.
and so if we go back to the 4 R's, it's the realization, the recognizing, responding, and resisting re-traumatization. So, like you mentioned, realizing how things affect people, whether it's a big T or a little t. And then being able to screen and realize, looking at, and again, this is across the lifespan, recognizing signs of trauma. We see it in our patients with dementia who may be in institutionalized settings. One of the things that I'll talk about a lot with people with dementia is that they come to the acute care hospital and I'll get this report of, oh, they're really difficult, or, oh, good luck with that, they're not doing anything. But you got to realize this is new people, new lights, new sheets, a lot of times new clothing for them. The room is set up completely different. They don't recognize anything or anyone. And if they're already, even if they're not aware that they have a cognitive issue or a cognitive decline, it's traumatic for them. Nothing looks right, nothing looks familiar, and that can be what we would perceive as a little trauma, but for the patient might be a huge trauma. And then, how do they respond to it? How do their caregivers that they're typically used to respond? And how do we, as maybe new caregivers, respond? And then how can we resist contributing to that re-traumatization? Because if you've got people coming in to the room who aren't familiar to the patient, and we don't know them, we just met them 5 minutes ago, how are we able to resist that re-traumatization? Because we don't know. If we don't have a caregiver present, we get a medical chart, we get a medical record. Sometimes we see the best or the worst on that medical record, right? We get information. Sometimes we go in and we're like, oh my gosh, this is going to be a hot mess. And you go in and the patient's like, hey, good morning, I'm hungry. Or you get the opposite. It's like they look great on paper and you go in and they're like semi-conscious and can't really do a whole lot for themselves as far as like self-feeding or even being aware of what's going on. So it really varies. And I think, again, having that training so that you can know how best to respond to your patient is really important.
Mm-hmm. Do you see Melissa's comment?
Yeah, I was just getting ready to read that. Mm-hmm. So Melissa says, East Tennessee here, just north of Irwin, our community was hit so hard. My school was set up as an emergency center. I go back to work tomorrow, which is why I'm here listening tonight. Thank you for being here. 10 families at our school lost their homes. One of them a student on my caseload. Hold on, I just lost my.
Don't even know, what state of mind my kids will be in. And
yeah,
I think it's wonderful that you're seeking, like, what can I do? What support, like, what is my role right now? How can I support these kids? How can I support myself? Because you also, that's what we would call trauma sensitive practice, because we know what the trauma is. So like we're sensitive, and we have made, you have also experienced on some level this trauma within the community. And I know we'll talk about the 6 pillars of trauma informed care, but what I really like to emphasize to people is, the importance of just being with and allowing space and being open for kids to process this in the way that they need to, because you're right. We don't know what state of mind they're going to show up as. We don't know how they're going to process this. We don't know how their caregivers have processed this, because that also plays a role. That attachment piece plays a huge role in regard to trauma. And so I think a big piece of trauma informed care is also showing up knowing I'm not necessarily going to know. So going and being like, I don't have the answers, but what I am going to do is hold space for their emotions and how they need to process things, and focus on being there as like a secure, safe place, and work to find out what's going to make them feel safe, which is the first pillar of trauma informed care. Is that safety is huge. But I'm sorry that you guys are going through that. I can't imagine. And knowing like they're probably not going to be at the capacity to learn at the same way that they were before this happened.
Yeah.
And that's okay.
Yeah. Because again, the first thing is to provide that safe space. And then, if this is a kiddo that you've already worked with, you've probably already developed some trust, which is the second pillar, is that trustworthiness and that transparency, where you're, it's perfectly fine for you to go in and just acknowledge what's happened and maybe not have goal-oriented therapy on day one. Because honestly, I've done that before with my patients too, who have been through TBIs or even domestic violence patients that, maybe their TBI was a result of that. And even stroke patients too. I mean, sometimes it's very traumatic for them to, and it doesn't really matter the age, but I do see it a lot more with the younger stroke patients, but their acceptance of what's happened is not there. There's a lot of fear. There's a lot of anxiety. There's a lot of especially if they haven't had good education, like quality education or community education, even, they really don't know what to expect. Not that anything can be predictable like that, but to have some sort of guideline of expectation of it's okay just to come in here on day one and just be where you are right now. And I'm going to meet you where you are right now. And that's pretty much it, is safety, trustworthiness, and just saying, I'm here. If you have questions, I'm here. If you don't want to say anything, I think both of those choices are perfectly great options.
Yeah, and the transparency piece, I didn't quite realize certain things that I did that were within this model. Like sometimes you do things, you're like, oh, like I'm doing that to make someone feel more comfortable. And that transparency also is this vulnerability, but the vulnerability can be very open, talking about how you're feeling, but it can also just be simple as like, we're vulnerable by saying like, oh, I need to go grab a snack. I'm so hungry. Or like, when you're at a wedding with somebody and you're like, oh my gosh, my feet hurt so badly. Like little things like that are being vulnerable and show that like you're a human. And so I think being as human as you can be, especially in this moment with your students and allowing them to understand, because when working with adults or working with children seem like everything's okay, it tells the person they're working with that like they might have to act like everything's okay. And so that's where that transparency piece comes in. The peer support is that third piece of trauma-informed care, which hopefully helping everyone feel within community in that specific example, but even just like, that's why I always say we build community in so many different ways. Like you can build community just you and the client you're working with. Like you can make that a community, but then it can also be community of like, in pediatrics, I try to find support for caregivers so that they have somebody else that's been through something like that. Or group therapy can help build community of like somebody that's been through something that they have. And so that's a big piece too, to feel like you're not alone, is huge within that trauma space.
Yeah. And I think that's where, like for the adult community, so many places have these disease specific support groups, but they don't often have really accessible support groups for things like TBI. It tends to be in larger communities or larger cities, more metropolitan areas, same with stroke, or it's an online peer support group. But again, during the pandemic, a lot of people were using these online peer support groups that was helpful for them. And so some of them have been able to continue on, like for Parkinson's disease and things like that. And then having that caregiver support group too is a really big important piece, I think, again, across the lifespan, because that's not something that's needing that caregiver support to see that someone else is like you or someone else has had a similar experience. It is just really helpful. And it's unfortunately, I don't think there's enough of those in smaller communities and more rural communities. And so that's something hopefully that we can work towards as CSD professionals, is trying to figure out ways to foster that and get it supported financially, because everything costs money and it can be a challenge to have a bigger health system buy into that if there's no financial reward, unfortunately.
Yeah. And kind of going off of peer support, collaboration and mutuality is also a really big principle. I mean, they're all important. That's why there's 6 of them. But and that piece of like, I want to choose goals based on what that person cares about. And I want them to know what we're working on, and I want them to know why we're doing what we're doing. I know it can be more challenging with different patient populations sometimes. I mean, I work from typically birth to 6 is my like most range, but I see up to age 40. I mean, we see adults at our hospital too. But for that collaboration piece, like I may not be directly saying to the child, like, this is, asking them what they want to work on, but I'm following their lead in other ways and seeing how they respond to their certain things and monitoring their cues, things that you can look for from is this person feeling dysregulated or not showing me signs of safety? Are like pupils dilating? How quickly are they breathing? Are they sweating? What is their body language doing? These are very, very subtle signs that you can kind of pick up on if somebody is starting to show you that they don't feel safe. And when you see those things, it might be important to kind of take a step back and communicate with them about what's going on. It's giving us information. Or if you're working with someone who, we all work with people that have differences in their communication, helping them. That next piece principle is empowerment, voice, and choice. So I want someone to feel empowered that they're making their own decisions. I want to give them choices, and I want to give them a voice to communicate that. So like Renee was saying, trying to give choices in as many circumstances as we can to help someone feel in control. Because oftentimes when you've experienced trauma, you felt not in control. And so the more autonomy and self-advocacy and empowerment that someone can feel, it really helps them feel safer because they have a say. And with both adults and pediatrics, for a lot of the people that we work with, their choices are made for them all the time.
Yeah.
And I think we don't recognize how often we're making choices for our clients and the people we work with without even realizing it, when they might want to make that choice.
Yeah. And I go back to TBI and dementia in particular, because a lot of times what you see is that the caregiver has really good intentions, but they're doing things like picking out their clothes, in a skilled nursing or long-term care facility, or even in assisted living, someone else is picking out the food that you're eating. They're picking out the time that you wake up, the time you go to bed, the time you eat your meals. Well, what if you're not hungry? What if you are? What if you're hungry? You don't have access to food in that sort of setting. And you do, again, you don't look at that as trauma, but it could be triggering. So for example, say you have someone who's dementia who lives in a long-term care facility, and maybe they had poor access to food as a kid. And then they're in this place where now they're dictated what time they can eat, what they can eat, how much they can eat. They maybe don't have access to a snack in between if they're hungry. And so it really is the best intentions, but we aren't looking at how that might feel to the person who has this outlying trauma that we're maybe not even aware of. We have a lot of patients in my area who were affected by a local farmers market that closed. It was located in this area that's a food court, like a food desert corridor. There's probably a good solid 5 miles, maybe more, between grocery stores. It's on a major highway. So it's not something that people want to necessarily walk down to go get food. And there's not a lot of restaurants in the area either that would be affordable. Plus, there's not a lot of them anyway. And so we don't think of those things as maybe a triggering episode for our patients. But for my patients, it definitely was. They all came in and were like, I can't walk to go get my milk or my hamburger or whatever they were going to go get at the farmers market that they had access to. Transportation is also an issue. So I think, we look at the guiding principles. You're talking about empowerment, voice, and choice, but then the 6th one is the cultural, historical, and gender issues. And for a lot of our older folks, There are a lot of cultural issues, a lot of historical issues. This area was very rural before I moved here. Like when I was a kid, this was a very rural area. It's not now, but there's a lot of history surrounding that with segregation and division of who lived where and who had access to what services, not only cultural things, churches, grocery stores, gas stations, pretty much anything that you can think of. And I'm not in the deep South, I'm in the mid Atlantic. So it's a little bit less of, at least in my lifetime, it's not been as predominant as it maybe was for my grandparents. But it's definitely something that we need to be mindful of because, nowadays we experience people from all different walks of life and all different cultural backgrounds, generational trauma, generational norms that maybe were not best practices for, what we consider to be safe spaces. And I think it's really impactful and definitely, again, makes us need to be, when we're talking about like cultural humility and responsivity, I think trauma informed care is a big piece of that we're maybe not making that connection to. Because when we're looking at culture, people are thinking like, okay, well, maybe this is a Latina person, or maybe this is someone who's Black, or maybe this is someone who's mixed race, or this is someone who is an immigrant, or their parents were immigrants. And it's not as simple as that, because a lot of our patients fit multiple boxes, right? So we can't pick one and not know about the other.
And, like neurodiversity affirming care, that falls under trauma informed care. That's that's recognizing someone's culture and their differences. And so I love thinking through these principles because it allows me to look at what I'm doing as a therapist and the courses I take, the type of therapy I provide, and I can kind of check myself and see, is this providing these for this person? But the big thing about trauma informed care also is allowing yourself to get to know that person, because you need to understand them. You need to learn about them. You need to learn about their differences in order to know what makes them feel safe, in order to know how they want to make choices, in order to know about their culture and their history and things like that. And so it gave me permission as a clinician to not just build rapport. I don't even love that term because it makes it seem like, oh, I'm going to get you to like me and then you're going to do whatever I want you to do. Where
Are you going to buy the car?
Right. Or it's like you have to build a relationship, and a relationship is full of rupture and repair, which is the other piece, that you're going to have moments working with someone where you might say the wrong thing, or you might think you're supporting them via touch, but that they really don't respond well to that. And the stronger the relationship you build, the easier the repair is. But when we go in too aggressive initially to try and work on certain goals or support them in certain ways that we haven't taken the time to build a relationship, the repair is more difficult because we don't have that foundation. And so taking the time, I will even say to clinicians, like, it is very skilled to work to understand someone, because we're looking at our lens. It's very skilled to take time to understand how they want to communicate. It is very skilled to take the time to learn about their individual differences, which is a DIR Floortime term of like, let's think about all these things that make up this person. And that's what I'm looking at initially when I meet someone, is not, okay, what's my plan of care takes a while, and my plan of care changes. Like I might write a goal and then I learn something else about someone and I'm like, oh no, that's not what aligns with who you are as a person or what I'm learning about you. And so giving yourself grace, which can be challenging, especially in settings that require a lot of productivity and you feel like you have to be like meeting these expectations of how this patient's doing and when they're going to go home and when they're going to get discharged. And like, that is incredibly challenging. But we learn both as adults and pediatrics within the context of relationship. And so that's a huge piece of trauma informed care, is recognizing that relationship building and trust, and again, working to understand that person, not just as what's their communication difference or what's their swallowing difference. Like everything is in the context of them holistically too.
Yeah, and I think that kind of goes back to the pre-existing condition versus the acquired, because I think sometimes people get hung up on the acquired is, the thing that's happened now, that's usually the reason that we're seeing them in the first place. But a lot of times the pre-existing stuff impacts now this new acquired piece, and that
Mm-hmm.
especially like in the school age population, or even with the college age, like TBI, sports concussion group, of folks. It's maybe they had ADD or ADHD to begin with, or some other sort of a language deficit or disorder that they were being treated for. And now that they have this new post concussion syndrome, because they've had 5 or 6 concussions now playing a sport, that trauma and stress for them looks completely different, and they may not be able to articulate that. And I'll give you an example. So I just I just wrapped up the TBI course I was teaching this fall from graduate students. And that was something that I tried to drive home to them, was that, just because you see someone with a TBI, yes, this is the acquired condition, but you got to look at all the things that happened before that. And how do you figure out? And a couple of them immediately were like, well, I'll just ask the patient. I'm like, well, a lot of times the patient isn't able to articulate that, or can't really, maybe they can recall it, but they still can't convey it to you in a way that's going to be meaningful to the plan of care, because you want it to be a shared decision making process for goal setting and treatment. But who can you access? So, one of them said, well, I go back to the school-based SLP, but this is someone who graduated from high school like 6 years ago. So maybe you could, but is that going to be your best option? It may be more like their friends that come to visit, or their coaches that are current, their family members, if you have access to them. You need to look at the old stuff, but you got to look at how that's related to the new stuff, if you will. And I think that sometimes gets confusing for newer clinicians, or clinicians who haven't worked in in one particular setting. Like, you're going to bring
Mm-hmm.
something from your old setting, but maybe the new setting isn't, you're not meshing yet. And it takes a little bit of time for that.
Are you taking advantage of our new amazing feature? The Certificate Tracker. The free CE Tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider.
Yeah, and there is some research coming out too, looking at trauma. You have acute, which is this one event that happens, you have chronic, and then you have complex, which complex can be a variety of things. And sometimes the acute can be not easier, but people can tend to show a little more resilience after that, because it's almost like this thing happened, I know it happened, I'm working through it, where like something that continuously happens or something that's very complex is a lot harder to process. And you may not always know what's going to trigger you or how that's going to linger. And I mean, I even think about, from my own perspective, like I had a friend who was going to be my stepsister, she went through a very traumatic event and was no longer with us. And my dad said to me, be careful, because you're not always aware of how these things affect you sometimes. And I remember like waking up with panic attacks and hearing noises, and like I didn't directly experience the trauma, but like I knew someone, and that secondary trauma can also, you have to be aware of like where those triggers may come from. And so that other piece of trauma-informed care too is being very self-aware and being able to process your own emotions, because it's hard. Like our job is very hard, and there's a lot of emotions, and we're giving ourselves to our patients, and we care about our patients because we're in this helping field, and we, even more so than other people, you know, other professions within like the medical field, spend so much time with the people that we work with and get to know them really deeply. And a big piece also of trauma-informed care is that attunement, and how it's really important to help them feel seen and heard, and attuning to where they are. We don't, and we do this, I feel like, a lot. I mean, I'm coming from the pediatric lens, but with a lot of kids where they have a big emotion, we're like, it's okay, it's okay, it's okay. You're fine, you're fine, you're fine. All that does is make that emotion bigger and bigger and bigger.
Mm-hmm.
If you allow yourself to feel an emotion for 60 seconds, it can leave your brain. But if you don't, it can live in your brain for up to 6 years. And so all we're doing by not attuning to someone that's experiencing something is making they're not able to process that emotion. And so, you know, if you walk in to see an adult that you're working with and you just notice that something's different or they're feeling a certain way, it's important to, we're not psychologists or like, you know, clinical therapists, but to at least know that we recognize that something is different or that they're feeling something, so that they feel heard, and the voice and the choice. Like, I may not be able to directly explain to you why I'm feeling this way, but like if I feel like you're there and you get it and you understand me, that's really, really important, because there's nothing more frustrating than like feeling this big feeling and feeling like it's just being shoved down.
Yeah, and I've definitely had patients where I've noticed that, and I'll even say to them, you know, I've noticed that today seems to be an off day for you, and maybe I'm wrong, but if it's something that you feel like we need to address, we can do that. And if you don't, if you're not comfortable sharing that, that's okay too. And I think that goes back to again, that choice and that voice, because we're saying, I acknowledge that something doesn't seem like how you've been before, and I'm going to give you the space you need if you want to talk about it. And if you don't, that's fine too. And I think for a lot of people that, again, I don't like that word rapport so much either, but it does really give that trustworthiness and that transparency of, you know, we've developed this, you develop this relationship with your patient. So they come in and they're usually typically a certain way. And so you will come in and notice that maybe something is off or different. And if you acknowledge that, then you get right away that transparency piece of, I see you, and what do you need from me? Because sometimes the therapy can be super informal and still be effective. So Joni asked about the 6 pillars, and so I put the first 2, well, I put the first 4 in the chat. Safety is the first, trustworthiness and transparency is the second, peer support third, collaboration and mutuality is the fourth, and then hold on, I'm losing my train. Empowerment is the fifth. So we talked about that voice and choice just now. And then the cultural, historical, and gender issues, which is also another community that really, I think, is benefited by that trustworthiness and transparency is our LGBTQ plus and the trans community as well, because we're seeing a lot more therapists who are looking at doing maybe transgender voice affirming therapy, and they certainly need to be trauma informed if you're gonna, in addition to being skilled as a voice therapist, you need to be skilled in the trauma piece, and how, you know, there's a triad of consent, and so that's adversity, distress, and strengths. So that adversity is how you screen, and the distress piece is that kind of making, again, that connection between triggering events and then whatever's going on currently. So is there something that happened in the past that now is contributing to what you're seeing overall? Is there deficits related to whatever this acquired condition is? And then those strengths of their intrinsic and extrinsic resources. So that can be, you know, a lot of times how I'll describe an assessment to a patient is, this isn't a test. It's a way for me to figure out what you're good at and maybe what you need more help with. And that helps me figure out how we can use your strengths to help the things that you need more help with and get that to be stronger too. And so I think that plays into that triad of consent piece, because it helps people just, again, you're meeting them where they're at. You're explaining it in a way that is palatable and digestible, for lack of a better word. Because I know when I was in the hospital, if I had someone that came into my room and said, "Hey, I'm like," and I'm going to say his name. His name was Mike. He was an ICU nurse, and he was fantastic. And he came in at 4 o'clock in the morning, and he was like singing my name in a little song to wake me up, which was hilarious. But he would come in every time, and he always told me his name. He said, "I know you probably remember me, but you just woke up. I'm here to take your labs, and I got to take your vitals. I'm sorry I woke you up." And it was like, oh, this is amazing. Like, if everybody did that, it's such a simple thing. And again, that goes across settings. I go into patients with dementia. "Hey, I saw you the last time you were here. You probably don't remember me, but my name is Renee. I'm a speech language pathologist, and the doctor wants me to take a look at how you're doing with eating and drinking." And then if I get the bonus of their family being there, I always say, "I'm so glad you're here, because I know," especially if it's a new patient too, "I'm so glad you're here because I just met them and you know them better than I do. So what can you tell me about, what happened before they got here and now how that's different?"
Yeah.
And I think, again, we don't think of that as trauma informed, but it really is.
Yeah, always. I mean, and I see it unfortunately all the time because I'm also now inpatient at Children's, and a doctor walks in and doesn't address the child, or they don't tell the child what they're going to do because they assume that the child doesn't understand. And I don't care what cognitive capacity you think someone is at, telling them what you're going to do, explaining who you are, giving that information is so important. I'm going to presume competence. And I'm also going to be really patient, because I want to give that opportunity for that person, child, whoever, to tell me no in whatever way they might want to. That's also why relationship is important. I know with the kids that I work with that maybe they work with a lot of really medically complex kids. I know what their refusal cues are. And some kids, some look very different. Like some, and caregivers, to your point, are very good at knowing what that child is communicating, what that adult is like, what they've been through, being that person that can report on a lot of that. And so we want to leave time for someone to show us what feels safe to them and doesn't feel safe to them. Touch is one of those things that, neurobiologically, it is a really wonderful way for us to be calmed, but it can also be a really triggering experience, especially if you have a lot of medical trauma where you were touched a lot and it was uncomfortable and it hurt. And, anybody that's been through something, in the medical setting, you are touched a lot to save your life and to help support you. But that's when we have to be very cautious about touch, and also teaching from that voice, choice, and empowerment. Teaching, I view it in the pediatric world, like I want to teach children that they have autonomy over their body. I want to teach everybody that they have autonomy over their body, because unfortunately we know that people with disabilities are at much higher risk to experience traumatic events that take advantage of their so we want to make sure that person feels safe to advocate for what they want and what they don't want too.
Yeah, and I think, and I don't know if anybody has this question, but I just wanted to say that, like, pre-existing stuff, we touched on ADHD and ADD and maybe prior cognitive stuff, but mental health, I think, falls in that category for sure. Addiction history is another one that I think is really important to acknowledge, because one of the things that a lot of times, in acute care and even in inpatient rehab, it drove me crazy that, especially in acute care, we get a lot of I call them repeat offenders, because we see them a lot, and they're people with addiction history, whether it's cocaine, meth, heroin, whatever it is, polysubstance abuse. And they come in and they come in like it's like on a rotating clock of every 6 months, sometimes 4 months. And what happens is their discharge disposition is always back home, right? It's always in the same environment, in the same space, which is typically not a healthy space already, because that's part of why they're already addicted. And the addiction treatment is never a choice for discharge disposition. So that's another like little food for thought, because it drives me nuts. I don't understand it. But we've got these things that increase the risk of lifelong health problems, from physical to psychological to emotional. And that addiction, I think mental health disorders already predispose you to that. And then
Yeah.
say someone gets in a motor vehicle crash and now you've got all this other extra stuff. And I think it's just trying to figure out how do we, I think some people are already doing a really good job of practicing in a trauma informed way and in providing a safe space, but they don't realize that's what they're doing. And maybe want more acknowledgement or maybe more support of how they can find resources. And so like for me, what wound up happening is, because I've been working with the brain injured population since the start of my career, and not exclusively, but like that's been a constant for me. One of the things that I really thought was important was not only the brain injury certification, because it doesn't necessarily make you super competent, but you do have to have a lot of base knowledge. You do have to look at research and statistics and figure a lot of that stuff out to pass the test, and then have this ongoing continuing ed, and that's fine. But two really important things that I want to touch on are, well, one is how you can get training. There is actually free online training for a lot of different places. I know, like in Virginia, we have something called Virginia Heals. It's HEALS.com training, and it's just modules on how to screen for trauma. It's different age groups, and it's actually really good, and it's free. But other states, their health and human services or social service departments will often offer free, sort of similar training, and you don't have to register or anything like that. I don't think I registered. I think I just logged it. I don't even know if I logged in. I think I just went to their website. But there is, for schools, there's a safesupportivelearning.ed.gov that has, and I hope it's still up. That was the Trauma 101 activity packet. That was pretty cool, because you can download the PDF, and it's not necessarily like a formalized training, but it gives you food for thought and more resources. And then the state of Oregon actually does trauma. They have a whole website, traumainformedoregon.org, and they have training modules that are specific to different things that you can look through. And then, of course, National Childhood Trauma Support Network.org.
That sounds right.
NCTSN.org. They have e-learning courses for childhood trauma. And so there are ways to, and again, a lot of this you may be already doing and you don't realize that's what you're doing, but those are really good resources for you to have, so that you can go back and say, okay, yeah, maybe I am doing that, but how can I maybe make that something for, if you're someone in leadership who can train staff, or if you just want to share it with your peers at your like your developmental meeting or your team development or team departmental meeting or whatever. I think it's really, really important to acknowledge that.
Yeah. Kim Barthel, who's an occupational therapist, has a lot of, I mean, she's amazing. You can even just go watch her videos on YouTube, and she talks a lot about like the neurobiology behind trauma. She also just sounds like a fairy godmother. Like she's like, I'll just listen to her all day. But yeah, I think that is, I do feel, and that's why like I try to emphasize that it are probably things that you are, if you're here, I feel like they're probably things that you are trying to do, but having a framework and having a definition and having more of that research to back it up can really be helpful. Especially, with leadership, with trying to bring it to light a little bit more, because it does come more naturally to some people than others, and that's okay. Even such subtle things as like in my TBRI training, trust-based relational intervention, which is through TCU. It was developed by Karen Purvis. It has a lot of great resources if you're in pediatrics. And they talk about like saying hello and goodbye the same way. Like simple things as like it feels safer, because when you are in fight, flight, freeze, like you're looking for little changes. And so people that are in that state of feeling unsafe, they're looking for subtle tweaks to tell them that something bad is going to happen. And so the more consistent you can be, the more helpful, even like getting on a child's level every time you talk to them, or sitting, if an adult's sitting next to them, like being on their level. Such things that are so simple to do, but we don't realize the impact that they can have. And so, but it can really, really change how someone responds to you and how they feel in your presence when you really try to meet them where they are.
Yeah, and the one thing I was going to say was, oh man, I had a smart comment. I lost my train. It was kind of the same, along
Like
the
saying
same
hello
lines.
and goodbye. Yeah.
Yeah, oh yeah, but so DIR now also has training, and as does Montessori for dementia practitioners, that is based on those same principles you use with kids, but a lot of it talks about getting on their level, being like open. I know even when I did nonviolent behavior training for when I first started working with TBI patients, like there's a certain way that you position your body in a way that's non-confrontational. You have like your hands are like your palms are up and open, and you're kind of have your elbows towards your body, but your hands are away from your body. Just really simple things like that, that again, if you work in a hospital setting, you may be trained to do it, but you may not be actually doing it, or maybe you are. I know what it was. Physicians and administrators at schools really respond well to research articles or that sort of trauma informed, if you wanted to bring that up to your administration if you're in schools, or your administration if you're in a hospital, they respond well to things like, I found this free training online. I have used that Virginia Heals with all kinds of, in the role I'm in now, group home providers, day support program supervisors and managers. And they all are like, they had no idea that it existed. Our state mental hospital SLP had no idea that it existed. And they all were thrilled to share it with their staff, because it's free and everybody loves a free training, but it's also supported by a grant. So it's, it's supported by a grant they had to apply for, that's affiliated with our state Department of Health. And so it's legit stuff. It's not like someone just made up some random like worksheet to train them on. It's actually grant funded. So that's pretty incredible, because especially with this grant, the more people do it, the more likely they're going to be able to expand it and continue to provide the training. But one thing I did want to mention too, because we talked about this at our talk at ASHA, this was probably for me when I was doing the research for this, one of the most bizarre yet interesting things that I found was professions that don't require any type of trauma-informed training for either their license or their renewal, at least not where I live in the Commonwealth of Virginia. Chiropractors, massage therapists, skin estheticians, cosmetic or plastic surgeons, physical therapists, and mental health state hospital workers. So back to what you said about touch, those are all people who are all up in your business. They're touching you all over your person, from your head to your toes, and that's insane to me. And I even my office was next door to the chiropractor that worked in the same practice that I did at the time. And she and I had an extensive conversation about it. And then when I went to my skin lady, she and I had a similar conversation and she kind of said, I've really never thought about that, but yeah, because she knows me because, I have the weird PTSD startle now from having worked in COVID at the hospital. So I'll have my eyes closed and she'll go to touch my face and I don't know that she's right there, and I jump every time. And now it's kind of a joke between us because we're familiar with one another, but it's really off-putting. It's
Yeah.
really off-putting. And I don't have necessarily I don't think I have a disorder, but if I had a communication disorder or some kind of physical disability or difference that, responded in that way, but you're not able to process it. If you had like you mentioned, our neurodivergent clients, I have a lot of clients with autism who are adults, like 30
Mhm.
plus years old. They have a lot of sensory issues, and I could see where like social stories and things like that are very helpful for them, prepping them to go to the doctor, the dentist, even going to their psychologist that maybe they've been to for 15 years, but they only go every 6 months.
Mhm.
So there's a lot of ways like that. Again, I think that we tend to prep our patients that we don't realize our strategies, but we can use things like social stories, visual schedules, walking through that scenario, doing some script training. And I know you have variations for that with with pediatric feeding disorders too. And it's a little different, but it's sort of like a same variation on a core
Mhm.
principle, really.
Yeah. Yeah.
And that's really how we kind of came to this whole topic. It was really important, I think, for Erin and I to make the connection across the lifespan, because so many times we try to, not we, but I think a lot of practitioners will isolate into this one space when really most of us are practicing along this continuum.
Mhm.
There's no guarantee that I won't get a patient who's 30 plus or 25 or whatever that Erin saw not right now, because you're still like, really young. But you may have seen them when they were like 7, and I'm now seeing
Uh-huh.
15 or 20 or whatever. There's no
Yeah.
guarantee that we won't see that. So yeah, I hope that this continues. And Melissa, sorry, I'm gonna read your comment. Thank you, ladies. I will just be there and be open for the little guy I mentioned earlier. He's a minimally verbal kiddo on the spectrum. So I think asking the family how I can best support him and them is a
Mhm.
good place to start. Yeah, I agree. We also have mental health professionals on campus, so I will see if any have worked with his family to see how to best support them. It's likely I'll have other kids on my caseload who've experienced trauma as well. Yeah, I agree. And you're welcome. And thank you for being here, Melissa. I know it's a lot. The natural disaster piece, I kind of wanted to start with that. And I think Erin will probably agree. We have a friend that runs a company called Play Spark, who's out of Asheville, Serena and Kylie. I got my t-shirt on. I don't know if y'all can see it. It's all the different butterflies. And at the bottom it says, "Notice the beauty in our differences."
Mhm.
Yeah.
Yeah, and it's just I think we're thinking of everybody, and that's also why we want,
Yeah.
we planned this ahead of all those things happening, but still being aware of how, and I think that's the question. People always want to know, how do I support people, who have experienced things like this? And really, being there with this little guy, helping him feel safe. Does he need more
Yep.
sensory support? Does he need you to just take him away from the space for a minute? And now having the language and the resources to also support that will be helpful. Thank y'all so much.
Yeah, thank you, Erin, for joining us. I love you and I appreciate
Anytime.
you.
I love you. If you guys are coming to ASHA,
Yeah, come
let us
see us.
know. Come see us. Yeah, but we hope everyone has a good week. Yeah.
Yeah. Thanks again, Erin. Great to see you, and we look forward to
Thank
seeing you
you.
again. All right, take care.
Bye.
Thank you for joining us for this episode of Brainstorms, Functional Neuro Rehab for SLPs. We have a special coupon code for our listeners to receive $20 off any annual subscription to Speech Therapy PD. Head over there to get ASHA CEUs for listening to this podcast and all other episodes. The code is Brainstorms20. 20 is the number 20. We appreciate your positive reviews and support and would love you to write a quick review. Also, subscribe. If there's a topic you'd like to see us cover in the future, you can email us
or comment in the comments section or message us on social media. Remember to go to Speech Therapy PD to learn more about earning ASHA CEUs for this episode and more.